I have 3 cases to present. So the first one is a 36-year-old male who was first seen at the other hospital because of HIV infection. That was detected on entry into military service in back to 2001. The baseline virus load was as high as 1 million copies per mil. The CD4 count 155. There was no opportunistic illnesses or hepatitis co-infection. So back in 2001, he started to receive zidovudine, lamivudine co-formulates, Combivir, and efavirenz. And virus load declined to less than 400 copies 5 months later. But the virus load remained less than 400 copies over the next subsequent 6 testing occasion between 2002 and 2004. But he was lost to follow-up in 2005. Again, 4 years later, he presented to our hospital because of cytomegalovirus retinitis in January 2009, when the virus load was as high as almost 800,000 copies and CD4 count 34 cells per cubic millimeter. So, well, we have to choose an agent combination antiretroviral therapy for these individuals. So, I will try to give you some argument or a rationale why we choose the regimen at the time. So the patient interrupt nNRTI-based regimen. So we looked at the SMART study. There was antiretroviral conserve arm. So there were 3 approaches to discontinuation of antiretroviral therapy. The first one is simultaneously discontinue all regimens, all agents. And the second approach was stagger. So the nNRTI was discontinued first, followed by temporarily continue nNRTI for 1 or 2 weeks. And the third approach was to switch to 2-NRTI plus protease inhibitor before complete interruption. So when the antiretroviral therapy was resumed, almost 88% of the 688 patients achieved re-suppression. But compared with simultaneous discontinuation of all 3 agents, stagger or switch approach had a higher odds ratio of achieving viral suppression. And nNRTI recent mutation detected in 16.4% of those individuals who simultaneously discontinued all 3 agents. So this is the earliest study just mentioned by Nick. So we decided to restart antiretroviral therapy with abacavir, lamivudine plus boosted protease inhibitor. Without any recent mutation provided. And the antiretroviral therapy achieved viral suppression within the next several months, but the individual, again, developed non-adherence to the regimens provided. And on the 2 occasions which viral rebound were detected, there were no recent associated mutation detected by genotypic assays. And when tenofovir was available in Taiwan, we switched abacavir lamivudine to tenofovir lamivudine because he was sort of intolerant of abacavir lamivudine co-formulated as Quevexa. And subsequently, tenofovir 3TC was switched to Truvada when Truvada was available in Taiwan. So he continued to receive Truvada plus Kaletra until October 2016, when there was, again, a rebound of viral replication. So the virus load increased to 16,500 copies. So we performed another recent testing which showed emergence of recent associated mutation M184V and G190GA. So according to the Stanford databases, we found that the HIV the emergent HIV strain had resistance to tenofovir FTC and low-level resistance to abacavir and potential low-level resistance to DDI. But the virus remains susceptible to darunavir, boosted zanavir, and lopinavir. All those three agents were available in Taiwan, but there were no resistance mutation to integrase and inhibitors. So when you look at the genetic barrier to emergence of resistance mutation, he failed the Truvada plus Kaletra, and probably because of non-adherence to the agent provided related to the diarrhea caused by Kaletra, boosted lopinavir. So when you look at the genetic barrier, probably we will be able to identify an agent which is more simple for the individual. So the patient was switched to Truvada plus dolutegravir once daily, and again in 3 months, just a couple of days ago, the virus load was less than 20 copies. So this is the first case. And the second case is a 33-year-old male patient who received a diagnosis of HIV infection in late 2013 with a baseline virus load of 186,000 copies and CD4 46 cells per cubic millimeter. And at the time, the tenofovir 3TC and nevirapine were begun in December 2013. The baseline genotypic resistance assay show no resistance-associated mutation. But after 4 weeks of therapy, the virus load declined less than 10-fold, just 39,200 copies 4 weeks later. So we were suspecting that either he was non-adherent to the regimen provided, or there probably minor variant that were not detected by the population sequencing. So the virus load declined less than one log after 4 weeks of tenofovir 3TC and nevirapine. So we performed another genotypic resistance assay and then switched the antiretroviral therapy to camavir plus boosted adazanavir before the resistance assay data were available. And then the virus load declined further. And the data came back with the emergence of resistance to tenofovir, to nNRTI. So there were resistance-associated mutations such as K65KR or and as well as 181C, which is resistant to nNRTI. So here is the data showing the resistance report. So the emerging HIV1 as resistance to abacavir, DDI, TDF, and intermediate level resistance to 3TC, FTC, and D4T. And as expected, the virus is now resistant to nevirapine, efavirenz, ripivirine, etravirine. But it remained susceptible to boosted protease inhibitor and zidovudine and all those integrase inhibitors. While he continued to receive camavir and boosted adazanavir, the reason why we choose this is just based on the second line or the earnest study just alluded to. But he was not able to tolerate zidovudine, lamivudine. So the first approach was to switch to, there was viral rebound while he was receiving camavir plus boosted adazanavir purely because of non-adherence and intolerance to camavir, zidovudine, and lamivudine. So the switch to Kaletra, boosted lopinavir plus dolutegravir was made just based on the second line and earnest study. So we were able to achieve viral suppression again. But again, Kaletra and rotagavir cause diarrhea and inconvenience because they have to be dosed twice daily. So we re-examined the previous recent report. So we decided to switch the antiretroviral therapy to dolutegravir plus boosted darunavir when dolutegravir was available in Taiwan in late December. And again, 3 months later, the virus load continued to be suppressed as low as less than 20 copies. And the third case is a bit more complicated because this 47-year-old male has been followed at our hospital for quite a long period of time. And he was receiving Camboviir, Zidovin 3TC, and Kaletra since 2006 until 2012. But during those period, he was not completely adhered to the regimen provided because of his working hours, night shift, and the intolerance of the antiretroviral therapy. And subsequently in 2012, he was switched to APACC 3TC, co-formulates Kaletra and Kaletra. The reason why he continued to receive boosted protease inhibitors was because there was adherence issue and concerns about emergence of further resistance-associated mutations. So that's a very difficult situation for us to decide which regimen to be given when there were no STR or higher genetic barrier agents available other than the protease inhibitors. And he was 47 years old and had hyperlipidemia with a total cholesterol as high as 283 milligram per deciliter, and he continued to smoke. So you would consider this individual as a high risk for cardiovascular events. So here, this graph shows the continued HIV replication despite the continuation of Kaletra and Kaletra. So in 2013, the genotypic resistance assay shows the emergence of resistance-associated mutation to protease inhibitor, to reverse transcriptase inhibitors as well. So here you can see the HIV-1 was had a high level resistance to boosted lopinavir, boosted azanavir, and low level resistance to boosted darunavir. And also the HIV-1 was resistant to 3TC, FTC. It's not unexpected. And low level resistance to abacavir and DDI. But it remains susceptible to tenofovir, AZT, and D4T, and all those nNRTI and integrase inhibitor. The color in the I highlight those drugs in red color because they were available at that time in Taiwan. So when we review the literature, we found in such kind of multi-drug resistance HIV-1, we have to use probably several active agents in this individual. So at the time, there was a publication from a French group, a trio trial. 103 patients who had a number of primary resistance-associated mutation to protease inhibitor, nNRTI, and nNRTI. And they were switched to rotagavir, etravirine, and darunavir. And the other nNRTI or optimized background regimen. And at the end of 48 weeks, almost 90% of them could achieve viral suppression with the Salvage regimen. So in October 2013, we decided to switch the regimen to rotagavir, etravirine, and boosted darunavir at 600 milligram all been twice daily dosing. And we add on atorvastatin, followed by switch to rosuvastatin for hyperlipidemia. And he sort of tolerated the red regimen well with sustained viral suppression. But hyperlipidemia continued despite the addition of rosuvastatin. And he worked in a hotel, and the twice daily dosing make life a bit difficult. So we look back all those published papers. We found that probably the rotagravir twice daily dosing could be switched to once daily dosing dolutegravir because there were no recent associated mutation to dolutegravir, and it could be dosed once daily. And in this setting study, here you can see there are a few patients who were put on boosted darunavir, etravirine, and dolutegravir. And 71% of the individual who had a optimized background regimen plus dolutegravir could achieve a viral suppression at the end of 48 weeks of follow-up. So we look back the recent associated mutation report, and then we found that the virus was still susceptible to tenofovir. So we probably could compose a regimen consistent of tenofovir plus 3-TCO-TC plus dolutegravir when it was available in December 2016. So the patient was switched to Truvada plus dolutegravir. And then again, 3 months later, the virus load remained less than 20 copies. So in summary, in these 3 cases, in patients who failed the first-line regimen containing 2 nNRTI plus nNRTI, a regimen commonly used, it's a regimen commonly used in this Asia-Pacific region, switched to boosted protease inhibitor, mainly supported by second-line, by earning study, and by select study. Switch to boosted protease inhibitor plus 2 or 3 nNRTI or boosted protease inhibitor plus rotagravir provide effective option in achieving high rates of viral suppression. But in those individuals who had emergent resistance associated mutation to multiple classes of antiretroviral therapy available, the optimized background regimens are probably identified by genotypic resistance testing with the addition of preferably a second-line integrase inhibitor will be effective in resuppressing viral replication. Thank you.